and very useful talk about the left atrium. You become an expert on the left atrium. Thank you so much for joining us this time. Now I think we will go on to the next speaker. Dr. Sanjay Theodore is here to tell us about the mitral valve. Dr. Sanjay Theodore has been a long associate, and he is a regular feature of our cardiac morphology. He takes great pride in being with us, and we take great pride in having him here with us. And over to Sanjay Theodore, mitral valve.
Good afternoon, everybody, and thank you, Jacob, for having me here at this innovative meeting. My topic for today is the morphology of the mitral valve. The mitral valve has been likened to various shapes, and most often it is referred to as shaped like a bishop's mitre. However, I think it will be simple and easy to understand the mitral valve annulus as a saddle-shaped structure. The two lowest points of the saddle is at the trigones, and the two highest points are at the midpoints of the leaflet attachment. The annulus is a fibrofatty structure which has elastic properties and has an important role to play in the pre-systolic contraction of the mitral valve. The annulus is not circular. It is more oval in shape with the antero-posterior diameter shorter than the intercommissionary diameter. There are two leaflets which attach to the annulus, the anterior and the posterior leaflets, and this is more accurately called the mural and the aortic leaflets, but for simplicity's sake I'm going to keep using the terms anterior and posterior. The two leaflets are continuous at the two commissures, the anterolateral commissure, which is closer to the aortic valve, and the posteromedial commissure, which is closer to the IVC. The leaflets have an attachment to the annulus, and the posterior leaflet has an attachment over 2/3 of the circumference, anterior leaflet over 1/3 of the circumference, and essentially they have an equal area. The height of the anterior leaflet differs between 2 to 2.2 centimeters and the posterior leaflet 1 to 1.2 centimeters. There are two prominent indentations on both the leaflets, dividing the leaflets into three unequal scallops. These indentations do not run up to the annulus. They stop short of the annulus and are very rarely the site of regurgitation in a healthy normal valve. The leaflets are further divided into three zones: the basal zones, the clear zone, and the rough zone. The basal zones are the zones closest to the annulus, and they contain small nerves and blood vessels and are continuous with the atrial and the ventricular myocardium. And they are sensitive to neurotransmitters and assist the annulus in the pre-systolic contraction. The clear zone, as the name implies, is clear, does not have any attachments, and is usually translucent. The rough zones give attachment to the cords, and these are found closest to the leaflet edges. The two leaflets come together and oppose each other and at a point called the coaptation point. And the height of the leaflets which are involved in this coaptation should be a minimum of 5 to 1 centimeters to have absolute competence of the valve. Now, when we study the morphology of any structure, it is important for us to understand the surrounding structures which could be critically injured in case of during surgery in difficult cases. So, around the mitral valve, we have the circumflex artery, the coronary sinus, the aortic leaflets, the AV node, and the bundle of his. Now, during a normal first-time mitral valve surgery, it's very unlikely that we're going to injure any of these structures. But when we have a small left atrium and an ischemic mitral regurgitation, or when we have a redo case or a small child, an overzealous bite can compromise any of these structures. Now coming down below the leaflets, we have fibrofatty strands which arise from the papillary muscle heads and insert onto the rough sole of the valves. These fibrofatty strands with elastic properties are very important in maintaining the stability of the valve. There are between 15 to 20 cords in a normal valve. There are more cords arising from the posterior leaflet and less cords from the anterior leaflet. There are three different types of cords: the primary cords, the secondary cords, and the basal cords. The primary cords attached to the very edge of the leaflet are very important to maintain the stability. Rupture or disease of any of these primary cords can cause flail leaflet and severe mitral regurgitation. There are two specialized primary cords, the commissural cords, which are fan-shaped and attach on adjoining parts of the leaflets. And these fan-shaped cords can be used for identification of a commissure in a severely fused rheumatic mitral valve. The secondary cords attach 5 millimeters behind the primary cords. And there are two sets of secondary cords which are stronger and thicker than the rest, and these are called the strut cords. And the integrity of these cords are very important to prevent prolapse of the leaflet into the left atrium and mitral regurgitation. The basal cords usually arise directly from the ventricular myocardium and attach to the basal portions of the posterior leaflet. These cords have clinical importance in ischemic mitral regurgitation, where they contribute to the tethering of the posterior leaflet. There is also a specific arrangement to these cords. It's very important to realize that the anterolateral papillary muscle gives cords which attach onto the A1 and the lateral part of A2 and P2. And the posteromedial papillary muscles gives cords to the P3, A3 and the medial part of P2 and A2. If during repair we cross any of the cords, it's highly likely that we are going to end up with an incompetent valve. Now, last but not the least, the papillary muscles and the ventricular wall. I'm not going to go too much into detail about these things because it will be covered later. But these are also an integral part of the mitral apparatus and are very important in both disease and in health. There are two papillary muscles, the anterolateral corresponding to the commissures. The anterolateral papillary muscle is usually very constant in its morphology and has a single head. The posterior posteromedial papillary muscle can be a little bit variable, and up to 3 heads can be found. And very rarely they can be very sessile and just come straight, the cords can arise straight off from the ventricular wall. And in disease, especially in ischemic mitral regurgitation, this papillary muscle and the left ventricular wall are the cause of mitral regurgitation. In understanding the morphology and the longevity and clinical significance of the mitral valve and the clinical interventions and treatments we can go ahead and palliate the patients, we need to understand the microscopic anatomy. I'm not going to go into too much detail, but basically the valve leaflets have three distinct layers: the atrialis, the spongiosa, and the fibrosa. The atrialis layer has elastin and collagen, which are arranged in a very specific manner, and these are very important in taking and reducing the strains developed in response to stress. The spongiosa layer has proteoglycans and glycosaminoglycans, and this is the shock layer of the mitral leaflet, which are useful in distributing the strains equally across the leaflet and reducing the strains developed at the maximum stress points. The fibrosa layer is the layer closest to the ventricle and bears the brunt of the ventricular stress and is the strongest part of the leaflet. There are two important cell types, the endothelial cells and the interstitial cells. The endothelial cells sense the stresses and neurotransmitters and cytokines are produced. There is genetic upregulation in the valvular interstitial cells, and the valve is plastic. The term plasticity means that the valve leaflet is in a constant state of flux. Repair and regeneration takes place across the lifetime of an individual, maintaining the integrity of the valve. However, the best example would be to take the valve leaflet from a small child and older adult and look at the microscopic features, which will tell us why the valve is pliable and mobile in child and more stiff and prone to degeneration in the older person. The young leaflet is going to be more cellular. The collagen arrangement is very defined. In an older individual, the number of cells reduces, the collagen is haphazardly arranged, there are areas of fibrosis and calcification. Now, it is also important that after looking at the basic morphology of the mitral valve, we need to know the morphological changes in a diseased valve. Only then we will be able to give a good palliation for the patient. The degenerative disease of the mitral valve is the commonest pathology found in this world and has a wide variety of diseases starting from Barlow's disease to Marfan's, Ehlers-Danlos, and almost morphologically normal fibroelastic deficiency. So if you look at the basic anatomic and histological changes, there is an excess of glycosaminoglycans glycans and proteoglycans, and collagen fibers are haphazard, and there are fibrotic changes in the valves, leading to the valve leaflets becoming elongated, thickened, and more prone to prolapse. The annulus is also affected to a large extent, and the annulus is dilated and it loses its saddle shape. The subvalvular pathology is also present. The disease of the leaflets and the annulus is also present in the cords. The cords are frequently more elastic, elongated, and prone to rupture. Now, when we repair these valves or go in for any kind of treatment of these valves, it is important to identify the abnormal morphology. So here, the main things are the annulus is dilated, it loses its saddle shape, and the stability of the annulus, which helps in the valve stability, is lost. So the annulus has to be repaired. The important thing we need to understand when repairing the annulus in a degenerative valve is that we should never put a small ring, and we should never measure the area of the size of the ring using intertrigonal distance, because frequently this is distorted. So the anterior leaflet area is taken and the ring is measured, and it is frequently advised that one size bigger than the size measured is usually used. Second thing is, these valves, when successfully repaired, end up, so about 15 to 20 of them end up with severe systolic anterior motion. So the important things here is the elongated posterior leaflet should be reduced to a height of less than 1 centimeter. And the anterior leaflet coaptation point should be less than 2.5 centimeters from the septum. So basically the coaptation point should not move more anteriorly. It should stay posterior to prevent systolic anterior motion. The subvalvular apparatus, when it is elongated or causing significant prolapse, can be repaired with neocords, remembering that the neocord should not cross the midline. The second important pathology which we see in the mitral and abnormal pathology we should recognize is the ischemic MR. Ischemic MR is a very complex type of MR where there is various pathologies involved. There is a type 1 type of insufficiency where there is an annular dilatation and the loss of saddle shape, and due to the increased sphericity of the failing ventricle. The second, there could be a type 2 type of insufficiency where there is caudal elongation, rupture, or papillary muscle rupture. And the third, the most typical form of ischemic MR, where you have a type 3A type, where you have a tethering of the posterior leaflet. The tethering of the leaflet again is not very symmetric. So it is more towards the A3 and the medial part of A2 and P3 and P2. So you have an eccentric orifice. And when we have all these three pathologies in the same patient, it is going to be very difficult to repair, considering the fact that the patient is already very sick with a bad ventricle. So these patients will be best served by going in for a total caudal preservation and a mitral valve replacement. But when you can identify the pathology correctly, you can go ahead and repair. And especially with the new rings, which take into account the increased anteroposterior diameter and the eccentric orifice, we can come up with a successful repair. The third and the most common pathology seen in India and of course Asia is the rheumatic mitral disease. And the valve has, in all the components of the valve are involved. You can have fibrosis and contraction of the annulus. So generally the annulus is smaller in advanced stage. In the early stages of disease, after the first or second attack of rheumatic fever, you could have annular dilatation. And most often these valves have commissural fusion, various levels of fibrosis, stiffening, and in older individuals you will get fibrosis and calcification along the areas of maximum stress, that is the edge of the leaflets, commissures, and the annular area. So these valves are seldom repairable, and if we do try to repair it, we're going to do too much to the valve. And one of the basic things in a valve repair is less is more. The more procedures you do, the more intervention you do on the valve, distort the valve in an effort to make it co-opt, you're going to have a valve failure earlier rather than later. So in these type of valves, you do have a subset, especially in the teens and early childhood, who will have repairable valves. Here the valves will be relatively pliable. There is very minimal fusion in the commissures, and usually you have an A2 segment prolapse. So in these patients, you can go ahead with the annulus reconstruction using a ring. And here you do not need a oversized ring. You can even put a normal, whatever the size the anterior leaflet area is, you can use that same ring. And you can use neocords to repair the prolapse, and you can open up the commissures if they are fused. Now, if we have to replace the valve, it is important that we preserve the subvalvular structures, because these subvalvular structures are very important in preserving the elliptical shape of the ventricle and preventing long-term left ventricular dysfunction. So the best way to preserve the valve is just insert a valve and valve. But in a rheumatic population, this valve and valve may not be possible because of the stiff calcified leaflets. Here again, it is important to try and preserve cords from both the leaflets. So you can excise the clear zone of the valve, and you can take the bites from the annulus onto the edge of the leaflets and plaster the entire leaflet to the annulus, and you should be able to get an adequate size valve. If that is not possible, small islands of tissue can be taken with the cords and tacked onto the annulus. But again, here we should be very careful that we do not cross the midline, and they should be tacked closer to the commissure areas. And you should be able to get a good repair. I think this, I will not be complete if I don't mention the mitral clip, which is coming up in a big way after the two trials have shown that it is efficacious and safe and can be implanted in the majority of patients it's attempted in. And now the cardiologists in the West are advising it for most patients with functional mitral regurgitation and a large number of high-risk degenerative disease patients. Here, basically the A2 and the P2, or whichever scallops are prolapsing, they are just made into a double orifice valve. But again, this is not the ideal situation because the subvalvular pathology is not taken into account. The annulus is not stabilized. So these repairs are not going to be long-term. But in the sick group of patients, they found that there is a significant reduction in the NYHA class and the grade of regurgitation. And there's no big difference in survival between high-risk surgery and this procedure. I'd just like to conclude by saying the morphology of the mitral valve has to be understood by all surgical students and interventional cardiologists, simply because we need to be able to identify the pathology in a diseased mitral valve. When we go in for intervention on a mitral valve, less is more. So do not do too many things to the valve to achieve the coaptation. You're going to have a valve which will fail early rather than late. Mitral valve replacement is an excellent procedure as long as you preserve the subcaudal apparatus, which can be preserved with the multiple techniques. Thank you.
Just have a quick look at the mitral valve. One is this is a porcine heart, and it will be interesting to look at the light placed into this heart through the left ventricular outflow tract, and you can clearly see the cords attaching to the rough zones, that is the edge of the leaflets. And then another interesting thing is the light is in the left ventricular outflow tract, so it's very clear that there are no cords arising from the ventricle attaching onto the anterior mitral leaflet. Now, this is a human heart which has been preserved in formalin, and again this has been cut through the left ventricle, so it's gone through the middle of the posterior leaflet. So you can see here the posterior leaflet is much shorter, it's about that big, and this is the anterior leaflet which is much larger in the anteroposterior distance. Here you can see the anterolateral papillary muscle, and you have the posterior papillary muscle, And you have the cords here. It's not very clear which are the primary and the secondary cords. But yeah, there are secondary cords just behind the primary cords here. It's very close. This is the secondary cords behind the primary cords. The scallops and all are not very clearly seen. But generally the A2 is the largest and the P2 is the largest scallop.
So thank you, Sanjay. That was a great exposition of the mitral valve. And we thought it perhaps would be interesting to see how the mitral valve moves, or rather how all valves move. So we have made a few small clips. What we do is we use bellows to open and close the valves, and we film it using a flexible scope. And so that's what we bring to you. So you can have a look at these valves and how they move. And following that, we would also show you how prosthetic valves function. So we would show you that as well. So that's the tricuspid valve in motion. You can see the large anterior tricuspid leaflet. This is the pulmonary valve in motion. So semilunar valves opening and closing, aortic valve opening and closing, and that's the mitral valve, AML and PML. This is the subvalvular apparatus, chordae tensing and relaxing. And I would show you the mitral valve a little bit better in this one. So that's the AML and PML opening and closing to bellows. We normally show all these things live in a cardiac morphology show, and we have these equipment here with us to show you these things. In this, we've had to use only recorded versions. This is a little device which we made to demonstrate the prosthetic valves. We have shown prosthetic valves implanted in the heart, prosthetic valve dysfunctions and stuff in the live cardiac morphology courses. Unfortunately, this comes to you with a little bit of corona limitations. So this is the bileaflet valve, and that's how it opens and closes. This is the single leaflet valve, the tilting disc valve. This is the Medtronic valve actually. So that's how it opens and closes. One of the age-old valves, the Star Edward valve, we would show you now. So this is how a Star Edward valve would function. This is an aortic valve. We know that because there are 3 struts in the cage. A mitral would have 4. So this little ball poppet moves up and down. So that's how that moves. If you do not have the required equipment, you could just pop an IABP balloon inside a bottle, and you could improvise, and you could use this as a teaching and as a learning method as well. So this is just to show you a few of the things which we normally do in our course, and we're only able to show you recorded versions of these. Now I think we would move on to the aortic valve. We have yet another interesting surgeon here with us, who's also been part of the team for a long time, Dr. Vijit Cherian. We trained together, and we're very happy and very proud to have you here with us, Dr. Vijit. He would be teaching us about the aortic valve.
Good afternoon, friends. So we move on with the next session, and that is the aortic valve. First of all, I'd like to thank Jacob for giving me this opportunity to speak today. Okay, thank you. So the anatomy of the aortic root is quite a complex subject, and some of the things I'd like to cover during this talk is that this is a vast area because of the developments in the treatment options for the aortic valve. So the aortic leaflet mechanism itself is fascinating. The aortic root is a small, central, deep area of the heart. And we must keep in mind that there are many new procedures in the last couple of decades. So it's important for the young surgeon to be well versed in the many anatomical and physiological aspects of the valve. So we must remember a genius born a few centuries back, Leonardo da Vinci, who actually figured out how the aortic valve opens and closes, and he was able to decipher a lot of that mechanism centuries back. Now, the Indian connection to the aortic valve are quite a few. So during the course of my talk, I will come across a few Indians who made significant contribution to the anatomy of the aortic root. So among the most well-known of the publications is The Anatomy of the Aortic Root by Dr. Anup Sood. He's a CMC Ludhiana graduate, passed out in 1975, and he's a cardiothoracic surgeon practicing at Detroit. And his publication in the Annals of Thoracic Surgery in 1984 has been the mainstay of the anatomy of the aortic root. These figures that you can see is from his article where he clearly describes the different relationship of the aortic root, the aortic leaflets to the surrounding structures. Yeah. So in this article, he also deals with the complexity of doing aortic root enlargements. So the figures in the center and the right tells us where the incisions are made for the Manugian and the Nix procedure. You can go on to the next slide. Yeah. Okay. So there is another Indian connection that we have. We have a biomedical engineer called Manoj Tubrikar, who worked many years with the Edwards Life Sciences Group. So he has studied the aortic valve in detail for the last 20-30 years, and he's gone into the biomechanics of the opening and closing of the valve, so much so that he has produced his own TABI system called the Optimum TABI system. So his publication about the biomechanics goes back 30 years back in 1990. The aortic root anatomy and the adjacent structures, as you can see in this diagram, are very well represented. It's right in the center. It's of the fibroskeleton of the heart. So it's related to the right ventricular outflow tract, the pulmonary trunk, the left atrium, and the right atrium. And so we'll come to this in more detail. While we are studying the morphology of the aortic valve, we have to keep in mind that the procedures which are possible or the options available to the patient today are quite a few. So you have the AVR mechanical valve, the bioprosthetic valve. Aortic valves can be repaired today. You can do a minimally invasive cardiac surgery, AVR, then the Bental's procedure, the David's valve sparing procedure. And today we have the rapid deployment of the sutureless valves, the TAVR, and the other problems that one faces as a surgeon is the small aortic root and the bicuspid aortic valve aortopathies. So these are quite a lot of pathologies and options of treatment that we face today, and the morphology of the aortic valve is very important to understand before giving the patient the options of these treatment options. So if you look at the aortic valve options today, there are quite a few. You have the stented valves, you have the stentless valves, you have the sutureless valves, and then you have the transcatheter valves. So all these have a very important connection to understanding the aortic root anatomy. So just skipping through the basics of the aortic root, you know that it is located, you have the right coronary and the left coronary sinus, the non-coronary leaflets. Below that sits the mitral valve. It's closely related to the fibrous skeleton. And on the right, you see the root, the anatomy of the aortic root. So it's a component which extends from the annulus, the aortic annulus, to the sinotubular junction, and includes the sinuses of Valsalva, the interleaflet triangles, and the coronary ostia. The bundle branch is closely related to the aortic valve, so it runs between the non-coronary sinus and the right coronary sinus, and it's in the subaortic segment. I'll come to a diagram later. And the right diagram shows you the mechanism of the aortic valve opening and closure, how the leaflets function. So you have different parts of the leaflets. You have the annular attachment, then you have portions of the leaflet which are called the hinge portion, the belly, and the coapting surface. These are very important to understand if one is planning to do repairs of the aortic valve. The aortic root, you have the true ventriculo-aortic arterial junction, and then you have the nadir of the leaflet closure. So that is what you see in the echocardiogram. So that is the echocardiographic annulus or the virtual annulus. Then you have the mid-sinusal level, where the sinuses are maximally dilated and where the coronary ostia take off, and up to the sinotubular junction, which is the junction between the aortic root and the ascending aorta. The aortic root, it is important to understand this anatomy, that it is a root. The aortic root is anchored by the pulmonary valve anteriorly and by the tricuspid and the mitral valve posteriorly. So it is right in the center. It's integral to the fibrous skeleton of the heart. The aortic root is basically a crown with 3 rings. So the crown is where the leaflets get attached, and you have 3 rings, which is the ST junction, the anatomic ventriculo-aortic junction, and the virtual ventriculo-aortic junction, which is the echo annulus. So this is very important concept to understand, because a lot of our treatments depend on the measurements from these structures. The aortic annulus is basically a scallop-shaped fibrous structure attached to the trigones, the aortomitral curtain, and the muscular and the membranous septa. So it is a complex structure, as you can see in this diagram. If you look at the 2D part of it, you will just see the leaflets arising from the annulus. But if you look at the 3D aspect, the whole thing forms a crown-like structure. The aortic root is a dynamic structure. So during early systole, you can see that the valve is just about to open. During the late systole, you have forces which go from the ventricle to the aorta. And once you have diastole, again, the valve closure takes place where the blood flows back into the sinuses of Valsalva. the ST junction to annulus relation is important to understand. Again, this is in keeping with the newer treatments. We need to understand this relationship. When it is the ST junction and aortic root is pressurized, the sinutubular junction is larger than the annulus. So there is a 1:1.3 ratio of diameters, if you can see in the top diagram. And when it is not under pressure, the annulus is larger than the ST junction. So this is it is a dynamic structure. You can see that there is a difference in the measurements during systole and diastole. This is important to understand when we use the rapid deployment sutureless valve. So there are some measurements that are taken, both the ST junction and the annulus, and there are some anatomies which are more favorable for deployment of these valves. So the Perceval valve and these other valves are the ones which are commonly used. The role of sinuses of Valsalva. So what David said was the aortic sinuses have no effect on valve competence, but are important in reducing the mechanical stress on the aortic cusp during the cardiac cycles by creating eddies and currents between the cusp and the sinus wall. So this is an important concept that though it may not be directly look at the competence, it definitely reduces the mechanical stress on the aortic cusps. So this is important to understand whenever we are dealing with the aortic root and doing any repair in this area. So the sinuses of Valsalva, as you can see, it forms a vortex. You can see that green dot, that is where it forms a small globe-like structure which results in the closure of that leaflet. The aortic leaflets, they are not always all equal. You may have equal cusps and commissures in some cases. In the other cases, you will have unequal cusps and equal commissures. And in the third case, you will have unequal commissures and cusps. So there can be variation in the